Hello, Mrs. Thomas. How are you feeling since the last time I saw you?
I've been all right. The same as ever.
Good to hear. The only thing that I noticed is that there is a slight increase in your weight.
Yes, I know. But it's so difficult to control it.
Have you been following your diet plan and getting some exercise?
I try. But I really cannot resist those sumptuous cakes and chocolates. I'm hungry all the time. And also, my friend Ingrid, her husband passed recently as well. And so I try to keep her company. That's also not very good for the diet.
That does sound challenging. I'd like to arrange for the diabetes nurse to talk to you while you're here today. She will be able to offer you some suggestions on how to manage the situation.
That sounds all right. Seems very helpful.
How are you managing your mealtime insulin at the moment?
It's very often very difficult. You know that sometimes I forget to inject my insulin, especially when I eat in a restaurant. And the dose, I think, is often incorrect. Because some days it is very high and some days it's very low, my blood sugar. And it happens after the meals. That's when I check it. And so I have to eat again. That's not very good for my weight, right?
I see. You've been checking your blood glucose regularly, both during the day and after meals?
Yes, I have. And I'm very surprised that my blood sugar is a variable. One day it's up very high, and then the other day it's very low. And so, especially in the morning, I immediately have to take an orange juice as soon as I'm awake. Last week, it was 2 o'clock in the morning. My blood sugar dropped, and I was sweating all over my body. It was a very frightening experience.
Your fasting glucose is going up and down, not the measurements after meals?
It's high one day, and the next day it's very low.
That shouldn't be happening.
Hello, my name is Andreas Liebel. I am the medical director at the Center for Diabetes and Metabolism at the Fachklinik Bad Heilbrunn near Munich in Germany. Our patient, Mrs. Thomas, has a couple of problems: high HbA1c, increasing weight, problems with her mealtime insulin, blood glucose variability, and of course, hypoglycemia. Let us look at her blood glucose variability first. This is a new and very interesting concept. Up to now, there has been no clear link between the level of fasting plasma glucose and hard endpoints. But when we look at the variability of fasting plasma glucose, then we can see a lot of meaningful associations. With increasing variability of fasting plasma glucose, hypoglycemia are also increasing, which is not surprising. Conversely, when the variability of fasting plasma glucose is reduced, so too are the hypos. And it is not only the hypos that increase. More variability in fasting plasma glucose also significantly increases the risk of both MACE, and MACE is myocardial infarction, stroke, or cardiovascular death, and it also increases the risk for total mortality. This finding is very relevant for our daily clinical practice. When patients tell us that their fasting plasma glucose are going up and down from day to day, then we really have to pay great attention, because they may have a relevant increase in their risk for hypoglycemia, for MACE, and for mortality. So the variability of fasting plasma glucose seems to be important, and it is therefore a good strategy to choose therapies with low glucose variability. Let's return now to our patient, Mrs. Thomas. The endocrinologist is going to explore the problem further.
We've talked about hypoglycemia before. When your blood glucose drops low, do you notice any of the problems that hypoglycemia can cause, such as feeling dizzy or disorientated?
Occasionally, I do. Sometimes it's during nighttime and sometimes it's during the daytime. And also, my eyesight gets a bit blurry more than usual.
And how often would you say this happens?
Oh, probably once a week, maybe twice. But then I take a quick snack, and that helps.
And what about when you're out with your friend?
Then I always have some chocolate bars in my handbags. I know, it doesn't really help for the diet, but it works.
That's definitely true, but it's better than losing consciousness. Hypoglycemia is a very serious problem that could result in you having to go to the hospital.
And what can I do to help that from happening?
I think the best thing right now would be to try adding another medication that could have a couple of benefits.
Like?
These days, we often prescribe an injection called GLP-1 agonist together with insulin. It actually stimulates your body to produce more insulin of its own when you start to eat. And it also slows down the emptying of your stomach, which automatically slows down the rise of blood glucose after the meal. Which means we can also stop your mealtime insulin before dinner.
And how will that help the hypoglycemia?
Well, we'll be able to reduce the amount of insulin that you're taking. The combination sometimes results in more consistent blood glucose levels with less hypoglycemia.
Sounds good. I'll try it.
A lot of people also find that when they take this kind of medication, they feel less hunger and fuller after eating. So they also lose some weight, and yeah, that may be another benefit.
That would be wonderful.
As we all know, the consequences of hypoglycemia, especially severe hypoglycemia, are very serious and can be even life-threatening. One of the things about hypoglycemia that is often not considered is the systemic effect that it has through the body, on the brain, on the muscles and on the skeleton, on the heart and on the circulation. And hypoglycemia happen much more often than we may believe, particularly in insulin-treated patients with type 2 diabetes, not only in those with type 1 diabetes. This has been demonstrated very clearly in the HAT study, which included an enormous number of insulin-treated patients. Therefore, patients and physicians fear hypoglycemia very much and adjust treatments in response to their fears. And as a result, hypoglycemia is a major barrier to improving glucose control. So one of the primary therapeutic goals in our insulin-treated patients is to reduce the risk for hypoglycemia. Combining now a GLP-1 receptor agonist, such as liraglutide once daily, with basal insulin is a good idea because it may allow us to reduce the insulin dose and thus reduce the probability of hypoglycemia. And this combination is not only good for reducing hypoglycemia, but also has some additional very important advantages. For example, superior reduction of HbA1c, of fasting plasma glucose, and of postprandial plasma glucose, and also reduction of weight. And these are the major goals in our patient, Mrs. Thomas. She is now returning to her endocrinologist after 12 weeks on the lower dose basal plus regimen and the GLP-1 receptor agonist. Let's see how she's getting on.
Mrs. Thomas, I see that your weight has gone down by almost 4 kilos over the last 12 weeks. You look very elegant today.
Yes, So you can tell that my clothes are less tight than before?
That is really marvelous. Was the information provided by our diabetes nurse helpful?
Oh, yes. She had one or two very good suggestions that I used, but I started walking every afternoon. But nevertheless, it's quite challenging.
Of course, but just try to make those helpful suggestions become habits that you use all the time, and gradually it will become easier.
It's all right.
Have you had any side effects from the new medication? Any nausea, vomiting, or diarrhea?
Now, no, that I recall, but I do feel, though, as if I am injecting myself all the time. And I know it's only one shot per day, but it's working on my nerves.
I understand. However, it seems to be helping. Your HbA1c has gone down from 7.8% to 7.0, so that's a great improvement. Are your blood glucose measurements more consistent now?
Well, it seems to vary from one day to the next, but actually, it is still low often.
So you're still having hypoglycemia?
Well, yes. Not quite as often, but still happening.
And how often would you say?
So perhaps once every 2 weeks. But it also happens during the night.
Including the dizziness, disorientation, and blurred vision like before?
Yes, but then I take a quick snack and soup, gone.
I would really like to get this under control so that you don't have to deal with it.
And what are you suggesting?
I think we actually may be able to reduce the chances of you having hypoglycemia and cut down the number of injections that you need at the same time.
Oh, and what do you suggest?
There's a treatment that combines a more advanced type of insulin together with the GLP-1 agonist that you've been taking for the last 12 weeks into one single injection.
Are you saying that I will only need one injection per day?
Exactly. The insulins that you're using at the moment go up and down in the blood during the course of the day. This newer insulin lasts longer, so together with the GLP-1 agonist, it's designed to give you more steady control of your blood glucose over 24 hours, even after you eat.
And that will still help with my weight.
You need to stick to your diet plan and try to get regular exercise, but yes, this medication should also help.
Sounds like worth trying.
The addition of a GLP-1 receptor agonist helped to reduce hypos to some extent in our patient, Mrs. Thomas. But in order to bring them down further and to really get this problem under control, we will have to switch her basal insulin to one of the latest generation preparations, which are able to adequately cover 24 hours and maintain a stable insulin level throughout the day. This stability results in very low day-to-day variability in the glucose-lowering effect during the entire day, and also low variability in fasting plasma glucose. I have already demonstrated at the beginning of our case report that the low variability of fasting plasma glucose definitely will lower the risk for hypoglycemia, the risk for MACE, and the risk for mortality. Insulin degludec is a latest generation basal insulin that has shown to elicit low variability. The good thing is that nowadays there are a couple of fixed ratio combinations of a GLP-1 receptor agonist and a basal insulin. One consists of a once daily basal insulin glargine U100 and of lixisenatide, a very short-acting GLP-1 receptor agonist. This is iglar-lixi. And the other combines insulin degludec U100, a very flat and very long-acting basal insulin, with the also long-acting GLP-1 receptor agonist liraglutide, and this is idaglira. Both formulations are supplied in one pen with just one injection daily. These newer preparations make it very easy for our patients, potentially facilitating also adherence to their treatments. The complementary anti-hypoglycemic effects of the two components of the basal insulin and the GLP-1 receptor agonist translate into improvement of glycemic control while minimizing the undesirable effects of each individual component. Minimizing hypoglycemia and weight gain with basal insulin, and minimizing gastrointestinal adverse events with a GLP-1 receptor agonist. The combination of a very long-acting basal insulin, such as insulin degludec, with a long-acting GLP-1 receptor agonist, such as liraglutide, has the additional benefit to lower both fasting plasma glucose and postprandial plasma glucose. This certainly makes it the preferred choice for our patient. The dual study program looked at the efficacy of the combination of liraglutide and insulin degludec of IDEC-LYRA, and the results were quite impressive. An HbA1c under 7% was achieved in every single major study. And at the same time, there was a very low risk for hypoglycemia in all the different patient types tested. And overall, most studies in the program showed weight reductions in the patients treated with a fixed ratio combination of degludec and liraglutide. The typical side effects of GLP-1 agonists, like nausea or very rarely vomiting, can occur. Also, something else that is very important for our patient, studies have shown that short-acting insulins, which are administered in a multiple daily injection in those patients with type 2 diabetes, can be stopped altogether and substituted by just one daily injection of a fixed ratio combination GLP-1 agonist plus basal insulin. So I believe that IDEC-LYRA is an excellent therapy for Mrs. Thomas because it will probably alleviate all of her problems. Her HbA1c will go down, the risk for hypos and her weight also will be reduced. And the therapy has very little side effects and is extremely easy to perform. One injection only per day. So thank you very much for watching today. I hope you find this program interesting and informative. Goodbye.